Okay, I'll be talking today about the speech-language pathologist's role in co-treatment in the medical setting. I thought that this was a good topic to cover because I feel like I personally really benefited from the co-treat sessions that I participated in as a student in my placement. I feel like I got to learn a lot about other disciplines, and it really helped me to see the big picture and kind of see the whole person of my patients. I was really interested to learn that there's some controversy with co-treatment. A lot of the program managers don't really like for therapists to use a whole lot of co-treatment sometimes, and major associations like ASHA really only support it in very specific situations. So today I'll talk about some advantages and disadvantages of co-treatment. I'll discuss and respond to ASHA's statement on co-treatment, and I'll describe proper billing procedures and provide a couple of examples on effective uses of co-treatment in the medical setting. Okay, so why is talking about co-treatment and learning about it important? In a study by Laura Zernick in 2011, therapists from various disciplines reported a lack of training in co-treatment. None of the speech pathologists or occupational therapists reported any training in utilizing co-treatment, even though all the participants in the study reported using co-treatment in their practice. The participants stated that they mainly learned how to go about co-treating through experience. So why do we co-treat? First of all, the speech pathologist is not an expert in all areas. We can definitely benefit from the expertise of other disciplines as well. A lot of times a patient might not tolerate too long sessions. This can be especially applicable for the patient that has to drive and receive outpatient therapy. They may not want to drive for two separate sessions. In some situations, the patient's safety may be increased, so that can certainly happen for a patient with balance issues, and so there may be situations where you want to work with the occupational therapist or physical therapist in those situations. And in a statement from ASHA in the Getting Started in Acute Inpatient Rehab, they stated that when addressing two different but complementary goals, it can result in an outcome that surpasses single discipline treatment. So some advantages of using co-treatment. First of all, the two separate disciplines may have overlapping skill sets that can be better addressed in unison. A lot of times there's better carryover of skills when the two disciplines come together, and the professionals can learn a lot from each other. Some disadvantages of using co-treatment. I'll discuss billing in more detail later, but it can certainly be a disadvantage in terms of not being able to bill the full time and possibly affecting the therapist's productivity. Many patients benefit from more one-on-one attention without having to kind of separate their attention between the two different disciplines. And finally, co-treats are often unplanned and uncoordinated. This was a point that was mentioned in the article by Zernick, and also something that I've experienced during my clinical placement. Co-treats would often come about when two therapists were competing for the same time, or when schedules were shifted, and so sharing the session was often the easiest option. But really that's not the best way to go about co-treatment. So following is ASHA's statement on co-treatment. This is published on ASHA's website. They state that co-treatment is appropriate when coordination between the two disciplines will benefit the patient, not simply for scheduling convenience. Documentation should clearly indicate the rationale for co-treatment and state the goals that will be addressed through this method. Co-treatment sessions should be documented as such by each practitioner, stating which goals were addressed and the progress made. And finally, co-treatment should be limited to two disciplines providing interventions during one treatment session. And so, most often, co-treats occur between occupational and physical therapy or occupational and speech therapy. There's not a lot between speech and physical. But these guidelines were created by the leading organizations on both speech pathology, physical therapy, and occupational therapy. So they kind of came together and decided what was important in addressing goals as a team. And so I think a lot of companies have made some progress on this. They've included, separate sections in their documentation to make sure that that the therapists are addressing the rationale and the how the goals were addressed in the session. Okay. Billing is going to be addressed separately depending on whether the patient is Medicare or Medicaid. So for Medicare patients, under Part A, it says that each clinician can report the total time spent treating the patient. So in that case, the total billed time may be equal to twice the treatment time. But they do note that the speech pathologist usually bills not for time but for a treatment session as a whole. So that's how that works with Part A. And then for Part B services, the total billed time will equal the length of the session. So whether each discipline bills for half, or one discipline bills for the entire session, or it's split some other way, the total billed time is going to equal the total time that the patient was seen. Okay, under Medicaid, co-treatment will be billed based on the particular state and the benefits offered by the state. So I was able to find a little bit of information on Medicaid Mississippi, and in their document, that was a frequently asked questions document, they stated that they do not cover co-treatment. They feel that each patient should receive individual treatment by one provider at a time. Alright, so here I've got a couple of, scenarios in which therapists might choose to use co-treatment. So in this first one, there's a cognitively high-functioning patient that is working on IADLs with a speech-language pathologist. So it could be some sort of cooking activity, maybe cooking a grilled cheese sandwich, and the occupational therapist may address the patient's balance, maybe using a rollator, safe bending and reaching, and just addressing their posture in general. And meanwhile, the speech pathologist may address safety awareness, so they may talk about, turning the stove on, leaving that on and walking away, taking out a knife, those sorts of things. They may talk about memory, so maybe they'll tell the patient where certain items are located, have a little bit of space retrieval for that patient to find those items later, and just the sequencing of those activities. Another situation with a sort of a completely different looking patient, you may have a profoundly expressive and receptive aphakic patient who has some sort of difficulty with their leg, possibly a recent injury. And so the occupational therapist in this situation may address the patient's balance and those safe bed to chair transfers in order to safely bear weight and manage that leg. Meanwhile, the speech pathologist may address establishment of a functional communication system, making sure that the occupational therapist and the patient are able to effectively communicate with one another, and maybe providing some training for the occupational therapist on giving the patient cues and providing environmental aids for the patient. So some of the implications just from the research and what I found, there's not a whole lot of research on co-treatment. I think definitely some more research on how people are using co-treatment and how it works and how it benefits the patient is definitely due. More training for therapists, and finally more policies governing how those treatment sessions should go about.